Hello everyone, today we're gonna talk about hyponatremia. What is hyponatremia? Defined as a serum sodium concentration of less than 135 milliequivalent/L, is the most commonly encountered and important electrolyte imbalance that can be seen in isolation or, as is most often the case, as a complication of other medical illnesses, e.g., heart failure, liver failure, kidney failure, pneumonia, cancer. It can be mild, moderate or severe depending upon serum levels. Mild, 130 to 134 millimoles per liter. Moderate, 125 to 129 millimoles per liter. Profound or severe, less than 125 millimoles per liter. Now, what are the signs and symptoms of hyponatremia? Symptoms range from nausea, malaise. In mild cases, can progress to lethargy, headache, and seizures. And in severe cases can cause coma, cerebral edema, and eventually death. Hyponatremia can be classified as follows. Euvolemic hyponatremia, hypovolemic hyponatremia, hypervolemic hyponatremia. Now let's discuss each type one by one. Starting form hypervolemic hyponatremia. Increase in total body sodium with greater increase in total body water. So Na plus conc will decrease. For example in heart failure, nephrotic syndrome, liver cirrhosis. This is due to decreased renal perfusion, salt and water retention, to greater extent, occurs, by renin-angiotensin system, so causing fluid overload. Also renin will induce thirst causing more water intake, diluting the serum more. The next is euvolemic hyponatremia. Normal body sodium with increase in total body water. Examples include the conditions in which ADH is secreted excessively. Pathophysiology is that patient is euvolemic but ADH level is high causing excessive water retention by kidneys. Urine osmolality will be high. For example in conditions like CNS disturbances, e.g. hypopituitarism, major surgery, trauma, pulmonary tumors, infection, stress, certain medications. Some of the common medications associated with SIAD are as follows. Chlorpropamide potentiates the renal action of ADH. Carbamazepine possesses antidiuretic property. Cyclophosphamide. Finally, hypovolemic hyponatremia. Decrease in total body water with greater decrease in total body sodium. Examples include extensive hemorrhage. Hypovolemia due to any condition e.g. dehydration. Overuse of diuretics especially thiazide. Thiazide diuretics, in contrast to loop diuretics, impair the diluting mechanism without limiting the concentrating mechanism, thereby impairing the ability to excrete a free water load. Now how do we investigate? 3 laboratory tests will help. Serum osmolality, urine osmolality, and urinary sodium concentration. Other problems to consider in the differential diagnosis are as follows. Hyperlipidemia, paraproteinemia, pseudohyponatremia. These conditions can cause false decrease in serum sodium levels, hence their name pseudohyponatremia. In these conditions serum osmolality is actually normal unlike in true hyponatremia in which it's decreased. Hyponatremia treatment and management. If hyponatremia has developed quickly then it needs to be corrected quickly and if it has developed gradually then it should be corrected gradually, to prevent demyelination. Symptomatic acute hyponatremia less than 24 to 48 hours. Give 4 bolus of 3% N/S 150 ml over 20 minutes. Repeat serum sodium, repeat bolus up to 3 times if not corrected. Note, in case of chronic hyponatremia serum sodium should not rise above 10 millimoles per liter per day, otherwise there will be a risk of demyelination. For hyponatremia that has developed gradually, management is according to the table below. For hypovolemic, isotonic saline is indicated. For euvolemic, water restriction is advised, and if that does not work, then diuretics or vaptins can be used. And the same goes for hypervolemic, we use diuretics and water restriction.